Hey everybody, welcome to Regulatory Joe. I'm Joe Boyle, president of ClearFile, and today I'm excited to introduce our latest topic, ghost enrollees in the ACA marketplace. So what exactly are ghost enrollees? The concept of ghost enrollees derives from a member or a prospective member who incurs no claims within that given calendar and or plan year. That's the 12-month rolling period after the time of enrollment. So enrollment again is from November 1st, and again now that has shortened over time for a 1/1 effective date of that current calendar year. I think at baseline we can all agree, whether you're sitting in an issuer seat, a carrier seat, or in a member seat, that low or underutilization of plans throughout a plan year every now and then for certain reasons, depending on what member demographic is actually purchasing your plan, is normal or seemingly normal. So what are some more legitimate reasons why a carrier may see low to no utilization for an actual, real, and legitimate subscriber? Some of these reasons could be for specific member needs in terms of a member being eligible for multiple types of coverage at one point in time. We also recognize that subscriber IDs and member IDs can become problematic. That's actually come up when we've worked with our issuer partners, because member IDs look and feel different and are tracked different from an ACA marketplace perspective because of how we need to report to state divisions of insurance versus other levels of coverage like Medicare, Medicaid, dual special needs coverage, or more. Another common reason for this could be a healthy population. There are a large number of actual healthy individuals enrolled into primarily bronze and expanded bronze plans. For those healthy individuals who want coverage, that pay for coverage but want the cheapest plan because they know they're not going to utilize that coverage. So some of you listening may be wondering, how does an issuer actually allow this to happen? Well, the root cause of ghost enrollees really comes from what we consider sales channels or distribution channels. That's really at the point of sale, or POS, of when a member or a ghost enrollee would essentially apply for a health plan, input information about that person or household, including income, demographic, zip code, address, and potentially even providers, or in this case, fraudulent providers that a prospective member is pretending to go to. So really, when we talk about point of service or POS, this can be driven essentially by a member themselves, whether it's a person or an individual inputting or keying in that data, or the most next common point of service is a broker distribution channel. So working with a broker and or a navigator or an assister, somebody who's actually qualified and in almost all cases licensed in the states that they participate in to help qualified individuals find an ACA qualified product, apply for that product, the best possible product that fits their medical needs or their healthcare needs based on what's in the marketplace and based on what they can afford. And once they find that qualified plan, it's a matter of applying, selecting that plan, and purchasing that product, essentially that point of service transaction. So once that business transaction is complete, essentially there's two things that happen. A prospective member goes on their happy way. What happens on the back end from a carrier perspective, which is not always commonly shared or commonly known from a process, is brokers do obtain a commission, especially from the individual marketplace. When you're actually selling the ACA product, that's how brokers are incentivized, because it's on an individual basis. Yes, could this happen with groups? Could there be fraud, waste, and abuse, what we call FWA with groups? In some cases, yes, but for ghost enrollees, the individual marketplace is really a monetarily driven opportunity for brokers that can actually earn a lot of money based on these sales. So it's a matter of what we break down into two categories, which is new business and renewal business. When brokers go out to sell, members can actually choose upon renewal, if you have a plan, to choose a different carrier by creating profiles of members, or what we're talking about today as ghost enrollees. You could inherently essentially enroll fraudulent members into multiple carriers at one single time as a broker. This has come to light in the media with multiple news channels. It's a highly complex, fraudulent process. But then again, what we're doing is we can harness this as a positive opportunity to educate our issuer partners, because now in a world where we are up against so many ACA headwinds, counting every member matters. Every single member you should be counting to make sure, how are they doing? Are we retaining those members? And are they actually real? We generally know that for small, medium, mid-sized carriers in the regional level don't have fully dedicated resources to enrollment operations. So we encourage you all to do the best you can, as enrollment is one of the last things that occurs in the ACA process. So we know, for example, first 8-10 months of the year, it's not the focus point of what a lot of carriers are actually looking out for as a priority. But then again, if you can afford some of the resources, think about it throughout your implementation process this year. So the way CMS is initially looking at this, while it is a seemingly newly emerging issue within the past couple of plan years, CMS has started to look at multiple plan year patterns. When CMS looks at identifying patterns, there's a couple different key drivers that, from an industry perspective, impact enrollment numbers, that impact large-scale trends that will really drive and uncover who is your ghost enrollee and who's an actual member and subscriber. At the front-end process, when agents and brokers are enrolling members into an actual ACA exchange plan, there's a number of questions that we spoke about earlier, including household income and dependent coverage. At that point in the application process, that household income is an aggregated number. That number could come from one job, but we do know that a traditional ACA member could have multiple part-time jobs. So again, when we think of an employment stance and perspective, at baseline, we know that members' income fluctuates over time. Now, from a broker perspective, a broker and an agent, their job is to make sure that a member applies with the most accurate information possible. Now, we know that over time, if you have multiple part-time jobs that change with hours or fluctuate with availability, you really want to put your best foot forward because that's going to drive the plan options available to you. So tying this back to the topic of CMS identifying patterns, we know that it is okay and that it's common for members to change jobs, and we should see fluctuation of income. What we shouldn't see is large-scale changes in a member's income on their application year over year that would swing a member inside or outside of subsidy eligibility for a certain threshold that would impact their eligibility or plan premium for a certain metallic tier, specifically speaking to the $0 silver plan and applicability when we talk about steerage of members inside a silver plan or outside a silver plan, especially without a member's knowledge and or understanding. Our rule of thumb is to keep any member communication, whether it's written or verbal, on a 3rd grade reading level. So as a broker and an agent, they have a duty to make sure a member fully understands the plan options available to them, similar to an assister, to making sure that they're making the most sound plan choice for their medical health care needs. So CMS can look at what we would just boil up to a high-level income trends. And one of the second easiest ways CMS can identify a pattern with ghost enrollees is members enrolled multiple times under different carriers and issuer IDs. One of the most common and easy ways to track a member's activity across a plan, whether it's claim activity or if they do plan switch, whether it's due to their own member needs or whether a broker chooses a different plan across bronze to silver, silver to gold, or gold to platinum, really we look at those shifts in terms of metal switching or plan switching. It wouldn't be uncommon, for example, when CMS releases their actuarial value calculator, that a member could fall from a bronze to silver plan pretty easily if you actually look at how the member utilizes that plan and how the value is calculated. But for example, a plan switch from a bronze plan to a gold plan or a silver plan to a platinum plan, that would raise an eyebrow even for somebody who's not even remotely familiar with the process. That carrier should be looking at that member anyways. Perhaps that member developed a chronic condition that they weren't expecting, or perhaps they had an accident or injury that they needed a very long stay at an emergency facility, resulting in them now enrolling into a different plan at a higher cost. So really, plan switches, again, they're normal. But then looking at those large swings and those ranges from CMS will be a very easy way for them to identify these patterns and work with carriers to reconcile large gaps in enrollment. So in terms of tracking ghost enrollee rates or high rates of enrollment in general, there's a couple things that you can look for. So generally in a year of enrollment, if you're a new issuer, the concept of growth is going to be slow. So you have that linear scale of members that grows over time, whether it's year 1, year 2, year 3, fairly seemingly easy to track from an operations perspective. Whether you have one analyst or a full-time or even a part-time employee monitoring that enrollment with a state exchange or a federal exchange, it could be easy. You may get one member that boomerangs out of their grace period that may get flagged as a ghost enrollee that you can really track. Is this person real, or is this a FWA case? And we'll get into that in just a second. For larger carriers, some red flags in terms of tracking high ghost enrollee rates may seem like it should be easy, but it's actually harder than expected. So what are some red flags that we can look at? Well, large carriers that have enrollments of not just thousands, but hundreds of thousands or millions of members at a time, it's very easy to overlook certain pockets of member populations that could be questionable. So what exactly should you be looking for during this analysis, whether it's very clear or you're doing a retrospective audit, is patterns of member behavior or what could be a ghost enrollee, and what those claims look like on a quarterly basis. Generally speaking, at the beginning of each year, there's just general concept of member behavior. When you go to the PCP and when you go to the doctor, it's generally the same time each year, within the same couple of weeks on the front end or back end. Really starting with your PCP could be one of the best ways to identify the greatest population of ghost enrollees, or at least slicing that top end population off of your population health data set, so it can be easier to manage and skinny down to figure out what's going on. So generally speaking, PCP would be a good driver in some of your top tier benefits. Even going back to the basics, from an ACA perspective, your 10 federal EHBs should be one of the best ways to filter down those 10 benefits. So all the way down to emergency room services, hospital services, inpatient, outpatient, specialist visits, or behavioral health. Some of those common benefits that really reflect in your ACA at day-to-day claims would be a way to identify these high enrollment trends. One other way that we recommend, if you don't have the resources internally, like full-time or part-time employees like we talked about, that can actually harness this population health data or claims data, is to work with your channel partners that actually manage enrollment and billing. Can be a valuable partner to you that has the data, that has the information and subject matter expert resources to help you analyze where is this enrollment data coming from and what does it mean to my business or my issuer. So really harnessing that is key, because the last thing you want to do is misrepresent your enrollment, especially to a state government, state division of insurance, and most certainly CMS. In talking with health plans, one of the most important things to do first is a root cause analysis. This could come from a couple different areas. When you enroll as a member into an ACA exchange plan, generally speaking, one of the first things you receive is a welcome packet. This is a packet that comes into the mail that is an explanation of your coverage and your benefits. Now, for example, like we just talked about earlier, a lot of claims activity, member activity, and communications is tracked by member ID, which is really driven by a member's social security number. So when a member applies for a plan or reapplies, or if a broker is using that member's information to apply for a different plan, that generally somehow gets back to their root cause of their social security number. So if a member receives a legitimate welcome packet for a plan that they legitimately enrolled into for a large carrier, that could be one red flag that that member is receiving a second welcome packet, a third welcome packet, at a different period of time within a year, a special enrollment period, or off cycle to their traditional enrollment period. Another item that a carrier can really dive into and look at, which is commonly confused with grace period activity and retroactivity, is the concept of instatement and reinstatement of coverage. So for example, for anybody close to the enrollment process with the ACA knows that the ACA allows a traditional member multiple chances to catch up with their premium coverage to be made whole while still receiving medical services even if they haven't paid their full bill. So the concept of reinstatement and instatement is commonly confused, where a member can actually fall outside of their grace period coverage. So really boiling this down on a simple level, if the member pays their premium in January in full, that's great. Entering the month of February, if that member defaults on their premium, the ACA will allow that member to seek medical services through the month of February. When that member arrives at the month of March and still doesn't pay their premium, the ACA will allow that member to still seek medical services through the month of March. By the end of that third month, the member must catch up with their premium, or else the coverage will be terminated. Now again, there have been many cases and conversations in the past of fraud, waste, and abuse, FWA, for the concept of grace period instatement and reinstatement. This is really where we're encouraging issuers to take a hard look at how your members are behaving in terms of payment versus premium. So this is working with your actuaries, this is working with your accounts receivable, your billing team, and even looking at your lockbox with your enrollment billing partners and understanding how members are paying their premiums. Are there gaps in coverage? And is it actually a grace period lapse? Or is there a concept of fraud, waste, and abuse of instatement versus reinstatement, a controlled process that's controlling members boomerang in and out of coverage instead of knowingly being able to catch up with their premium over time as allowed by the ACA? And another way health plans and issuers can look at this process to really harness ghost enrollees and get ahead of this for the next plan year is to partner with your health plan actuaries to work on your risk adjustment process and to look at the numbers and to really work through the large payments to and from CMS that ensure some of the members that need the most care, really taking a look at where those members came from, what's the utilization of those benefits that are driving those payments. Because again, from a broker perspective, really we're looking at those enrollees from a point of sale perspective, like we talked about earlier. Point of service, broker receives commission. That member could be real or that member could be fraudulent. What may not occur until over a year later, 12 months, or even for that matter, up to 18 months after that broker makes that point of sale transaction is the risk adjustment payment to and from CMS. So when that risk pool gets filled up, that could be driven by fraudulent members. We can walk it back and say it's a small percentage of the whole population. But even if it is a small percentage, it's still driven by how carriers are paid and how they make money. And essentially, that's how that trickles down to how they make business decisions, how they inform their ACA product and drive those members. So again, getting ahead of that, partnering with your plan actuaries will be important because that, keeping in mind, is a federal process. We do know that just inherently CMS is deploying more thought leadership behind the audit process. So again, be mindful of this as you grow your membership. So what are some best practices that we recommend all listeners and our health plan partners out there to follow? So again, like we talked about, if you don't have the resources to staff a full-time employee or even part of somebody's time to help evaluate the current enrollment and billing process and track your members on a intermittent basis, like we said, on a quarterly, on a monthly, or even on a weekly or daily basis, utilize your channel partners. Another thing we're big proponents of is putting in fail-safes or escalation points into any process. So building one process and writing it down on paper is one thing. Making sure you have a tiered approach to understanding member escalations that can actually uncover a fraudulent subscriber is key. For example, developing FAQs or talking points for your service center or call center staff could be a nice avenue where in the event a member does call in, an ACA member does call in during enrollment, after enrollment, or throughout the year, that agent, that call center representative has talking points or a desk reference if that member inquires about getting a duplicate welcome packet or a duplicate communication. That could be a signal point or an escalation point that could uncover some type of ghost enrollee or fraudulent process. So really building that process, but taking it a step further to educating your organization about the potential. Even if this is a small potential, in some cases, you really wouldn't want to put anybody in that position to not be able to field that question or situation. And finally, what I think is a common misunderstanding is enrollment is quantified to the period of time where a member enrolls on November 1st of every year on the exchange, and with the exception of off-exchange products or intermittent special enrollment periods, which happen every now and then, it's really contained to that period of time. What we would also recommend is intermittent checks or marketplace integrity checks within your company every quarter, every month, even outside of the traditional enrollment period to monitor enrollment activities, to understand grace period boomerangs, like we talked about, instatement and reinstatement of coverage throughout the year, and understanding that member payment behavior, not thinking about enrollment as just a singular event that starts in November. It should be a core part of the business process that you're implementing throughout the calendar year. And I know we covered a lot today, but really just as a final thought and a takeaway, understanding ghost enrollees, while it may seem like a small population out of the broader ACA landscape across every state in the country, by building a business process, we can set goals to reduce that number of false enrollees. Implementing that process will be important, but then also setting goals to understanding your total population of ghost enrollees and setting targets to reduce that population. Setting goals to incrementally reduce ghost enrollees or false subscribers over time will be very important because we do know that fraud, waste, and abuse is very apparent and recurring in the ACA marketplace. So thanks everybody for listening in. Give us a like, give us a share, and we'll see y'all next time.